So good morning or good afternoon, everyone, depending on what time zone you're in. This is Lisa Dulski-Watkins with the Millbank Memorial Fund Multi-State Collaborative. Today we're hosting one of a series of monthly webinars based on topics that are relevant to the Comprehensive Primary Care Plus and other aspects of multi-payer primary care transformation. I'm delighted to have a trio of excellent presenters who will be sharing their experiences today on a particular topic in Kansas City. And I also wanted just to do a little bit of sort of housekeeping just to make sure that this webinar goes well. Just for everyone's edification, I have just started recording this webinar. We will be able to share it on our website and people will have easy access to it. I'll let you know when that gets posted. Just as a reminder, there is an upcoming large meeting in May in Baltimore. The Comprehensive Primary Care Plus is having their 2018 annual meeting in Baltimore on the 8th of May at the Baltimore Civic Center. I'm sure all of you have seen notices of that already. And in addition to the meeting itself on the 8th, there is going to be a separate meeting related to the CPC Plus on the 7th of May, also at the Civic Center. So I'll be, we at Millbank will be hosting a meeting in the morning. Invitations actually will be going out this week. And having that be part of the process, we're going to be focused on, is everyone hearing a lot of background?
Hearing an echo. Yeah.
Wow. Okay. Hopefully that will stop. So I wanted to turn it over to my colleague Susan Stewart, who is working with the Land Pack. They also are hosting a meeting on the 7th in the afternoon. We'll be physically in the same space. Millbank in the morning, Land Pack in the afternoon. Susan, can I just turn it over to you to make a brief announcement?
Yeah, that sounds great. And I just want to check that you can hear me. Okay, good.
Yeah.
Definitely some reverberation on the line. Okay, so I'll just try to proceed. So as Lisa mentioned, I think all of us are pretty excited about the meetings, the CPC Plus meetings that'll happen in Baltimore on May 7th and 8th. The PAC in particular will be running a meeting in the afternoon of May 7th for payers and conveners. And this will really dovetail really nicely with Millbank's meeting in the morning. Millbank will be meeting, starting from breakfast all the way through 1 o'clock. And graciously offering folks meals. And then the PAC is sort of explicitly going to pick up at 1 o'clock in the afternoon. And the PAC meeting is really going to focus payment. Oh. Lisa, can you hear me? Did I go on mute there?
No, I had to mute everybody and I unmuted you just now. So I think we're all set.
Great. So sorry, just might be repeating myself. Back on the agenda. There'll be about an hour focused on where plans are with constructing and implementing the alternative to fee-for-service payment, informed by some data and some live polling questions where people have a chance to answer questions anonymously about where they are and give some feedback about what technical assistance they might continue to need from the PAC, from the CPC team, et cetera. So we'll do that for about an hour. And we'll take a short break. And then after that, we'll come back for a discussion really focused around care management, have the opportunity to look at some of the 2017 reporting done by the CPC Plus practices with regard to care management in the various regions, and hopefully really have an interactive discussion with the payers and the conveners focused around what are they seeing happening with the practices and care management in their markets what do they think the practices need? What types of requests are they getting as the regional forum, as the payers? And we'll be issuing some discussion questions in advance of the meeting, really sort of focused on these care management issues, just to get people thinking in advance of the meeting. So the payers should see that coming across as a distribution from the PAC, those discussion questions, you know, anywhere from tomorrow to sometime next week, depending on how quickly the wheels turn, and then we'll be looking to get that information out to the conveners as well, either sort of through CMS or perhaps collaborating with Millbank, trying to make sure that that's available. And then we just encourage everyone to register for the PAC meeting. There's an actual URL that you need to go to and register. It's a pretty simple process, just sort of name, rank, and serial number. And I think that's it. I think we're just, and Lisa and Edith and I have been coordinating, you know, off stage left about the 2 agendas, and we're just really happy to be sort of doing this work in coordination with Millbank. So Lisa, maybe I'll stop there and take questions or any comments. We'd love them.
Sure. Let me unmute the crew. Thank you, Susan.
Thank you, Susan.
Which immediately put the echo back on. But are there any questions for Susan right away? Okay, then I think what we'll do is get started. I'm going to mute everybody but myself for the moment and introduce our speakers. Thank you, Susan, for sharing that. And we look forward to gathering together in person in May. Okay, so welcome to our webinar. I'm sorry for any technical difficulties. I've been hearing a lot of echoes. I've moved a few things around and hopefully that will improve things. It is my great pleasure to introduce the team from the Blue Cross Blue Shield organization of Kansas City. They serve both Missouri and Kansas. It's a very strong regional organization. They've agreed to talk about their experience working with the self-insured employers, their ASO organizations. They have specifically been working in their value-based programs, mostly medical homes. So this has great relevance to the CPC Plus, but not necessarily directly with their CPC Plus program. So it's a continuum from where they began to where they are now. So I'd like to introduce the team that will be presenting. First, we have Qiana Thomason, who is the Vice President of Population Health Solutions for Kansas City Blue Cross Blue Shield. We have Karen Johnson, who's the Vice President for Healthcare Insights and Partnerships, also with the Blues, and Z. Haley, who is the Director of Employment Services. All of whom will be sharing their insights and how they went through this process. This is of great interest to all of us. The majority of people insured by employers are in self-insured programs now, and it's clearly an issue that creates a great deal of concern in terms of sustainability and frankly fairness as we move forward in this. So what I'd like to do is hand the mic over. I'm going to unmute our friends in Kansas City, and we will get started.
Okay. Good morning. This is Qiana Thomason in Kansas City. Can everyone hear me, or can at least you hear me, Lisa?
I can, and you are all set.
Okay, very good. Thank you for that introduction. We have one minor switch out. Z. Haley had a conflict today, and will be joined at some point by Suzanne Pendergrast, who is an employer sales consultant for us. So thank you for calling on us to share our experiences in this space. We're very happy to be engaged with Millbank and find great value in collaborating with the payers that are involved. So today, as Lisa mentioned, we just want to share our experiences and how we've cultivated and driven value here in Kansas City, and how we've brought our purchaser community along, specifically our ASO employers along, as well as our broker community. And delve into some of those details for you. Just to level set everyone and orient you to our plan, Blue Cross and Blue Shield of Kansas City, or Blue KC, is a locally governed nonprofit plan. Our service area includes 32 counties, 30 in the northwest corner of Missouri, and then just 2 counties in Kansas, the 2 most urban counties in Kansas. We have about 1 million members, with many of our members out of the area. We are largely a commercially driven plan. We do participate in direct pay. However, we exited on exchange and off exchange business with the exception of some grandfathered and grandmothered plans for 2018. We also have a small but growing Medicare Advantage line of business that has just over about 12,000 members. So in addition to that, we're largely a PPO-driven community. I think for the most part, our funding mix is about 60% ASO, 40% fully insured, which has changed dramatically in the past, I would say 4 to 5 years. It used to be the reverse, with about 40% ASO and 60% fully insured, which makes this conversation and our decision to include ASOs in our value-based and alternative payment model agreements that much more important, as they represent the lion's share of our business at this point. Just some quick facts in terms of our journey through alternative payment and care delivery models. We entered into the patient-centered medical home space. That was our first advent into value back in 2010, and we did that as a pilot. That program or pilot was largely successful, and it became a full program around 2012. And we currently have just shy of about 350,000 members in the program, over 800 physicians participating, primary care physicians and family practices. And it features really a total cost of care model where the providers receive a risk-adjusted per member per month fee, a care coordination fee, or base payment is what we call it, and then a performance multiplier on top of that for their cost and quality performance. So we've really reaped demonstrable results with respect to cost and quality in this market, and specifically when you compare our members who are engaged or attributed rather to medical homes versus non, you see significant differences and improvements in the cost and quality realm. We applied for CPC Plus early on with CPCI, and at that point in time was not accepted, but continued on our value journey and just working with our provider partners in this community, bringing that forward to, I guess it must have been 2016 when our providers made us aware of the CPC Plus opportunity. It was somewhat of a no-brainer for us to get involved, as our medical home program was very strong and aligned almost identically with the CPC Plus Track 1 model, at least. And so we were the inaugural payer to get involved with CPC Plus in this market, and we're thankful to be joined by United Healthcare. In addition to that, we are growing our ACO footprint. We have ACO partnerships with our local Children's Hospital, Children's Mercy Hospital, Children's Health Network, as well as Centris Health, which is a more recent clinically integrated network, or ACO, comprised of a local IPA, an academic medical center, and 2 independent hospitals. So our journey through value has come a long way, but I think we still feel like we have a lot to go, a long way to go. But I will say that we do feel like we are certainly accomplished in the area of including our ASO customers in this space, and wanted to share our experiences in that regard, some lessons learned, and some key insights for the other CPC Plus payer partners. With that, I'm going to turn it over to my colleague, Dr. Karen Johnson, who will share her insights as she was a key contributor and very impactful in cultivating this with our ASO customers.
Thanks, Qiana. And just as point of clarification, that's Dr. Karen Johnson, PhD, which sounds weird and new because it just happened. I just defended my dissertation this spring, and but thank you for that shout out there. I'm not an MD. Don't ask me any clinical questions.
No, we're going to all applaud. We're going to all applaud for you.
Thank you, Lisa. I appreciate that. So I'm going to try to quickly hit on 3 points that I think are relevant to this. And because I want to make sure we have time for as much conversation as we want around this, because this is just our experience and our perspective. There are others certainly. And I'm going to talk a little bit about, really the decision point around whether to have ASO or I'm going to call it a broader umbrella of alternatively funded employer groups in this, because for us, pure ASO is a fairly small segment, but we have a lot of employers over 100 lives that fall into some form of alternative funding where their claims exposure or their claims expense is exposed to them, and they see it as their part of their value equation. So that was a big and growing segment of our business, as Qiana pointed out. So the decision to do that or not do that and when, and then once we made the decision to actually include them in this initiative, how do we share those costs, those new provider payments with them? What does that look like? I call that to show or not to show. Do we really reveal these or not? And then once we made those decisions, how do we really stand behind that in the market, and how do we introduce that to the market? And I think that is also a really key piece of the success that this plan has had. So I'm going to back it up and say that in 2010, actually I came on board in 2011 as a consultant to the plan. As I was marching through my PhD journey, they were good enough to take me in as a consultant while I was in my classroom work. But for those of you who don't know me, and I haven't had the opportunity to get to know you, I'm a reformed or recovering broker, benefits broker. So I came from a perspective where I could sort of bring that outside in perspective to the health plan, which I think was helpful, and why I was a part of this journey early on. So Qiana mentioned the program launched in 2010 as a pilot, and I think it's kind of interesting because while I didn't have a seat at the table at that moment, coming on fairly soon after that, my impression is there was not much hesitation around, we need to include all of our members in this initiative based on the belief in the model, and I think also based on the belief that we've got to really have a presence in the provider mind space, and we need to get their attention. And if we come with a small segment of our membership, we're not going to gain that traction with the providers that we really want to have. So from 2010 to 2012, there was really no big question. All of our members are in. So once we went full program and started adding providers, and the stakes became a little bit higher financially, that's when the real question became, what do we do about sharing this new provider payment with our ASO customers? Because up to that point in time, Blue Cross had been fully funding that payment for all members, whether they were ASO or fully insured or without regard to that. So when that decision point came up, though, around 2012, there was a lot of energy around, yes, we have to do this. It makes sense. We were seeing good early directional sort of movement on cost and quality. They're getting value out of this. This seems like a no-brainer. Let's do this. But as we really dug into the decision, we realized the complexity of passing along a new payment on top of trending costs that employers are already uncomfortable with. So I think that the decision became a long, involved conversation. And I think one of the keys to the success, it was not a healthcare transformation or pop health team decision. It was a very collaborative conversation between the team that was deploying on the provider side and building the program and the team that was delivering the messages to the market. So really those conversations stretched on for probably 1.5 years to 2 years before the decision was made that yes, we're going to reflect these new payments as an expense, as a claims expense to our ASO customers, and that launched on 1/1/2015. So in the run-up to that, once the decision was made, there was probably a good 6 to 9 months of time spent working with the sales team on how do we deploy this. And this is the to show or not to show conversation that I talk about. Because I think in the early days of this, even though the payments to primary care were meaningful, and there probably could be some discussion on that point, but while they're meaningful to primary care in the scheme of total cost of care, it's a really incrementally small expense. So, but the minute you call it out as something new and different, it gains scrutiny. So the temptation early on was, so let's just bury this somewhere, and I don't mean bury in a bad way, but let's just put this in the claims expense and let's not call attention to it. The counter view to that was, this is important. We need employers to understand that we're paying primary care providers differently for a very specific purpose and reason. Because fee-for-service payments don't recognize a lot of the real high value services that we want primary care providers delivering to our members. Follow-up calls, transition of care calls, outreach with specialists, extended hours, all of those things that they weren't getting paid for that we wanted them to do. We needed to give recognition to that. And so actually reflecting the payment as an explicit line item on the invoices that go to the self-insured customers and really calling it out and talking to it. I call it owning that. Really owning that decision is something that the plan debated significantly, but they came down on the side of this is the right thing to do. From there, we moved into the phase of our journey, which I would call owning the decision in the market. And that is really spending a lot of time invested in training the sales team. And this is not just training the sales team on, hey, we have this new payment, this is where it's going to show up on your claims invoice. But we spent a good 3 months training the team around why. So we had 4 90-minute training sessions over the course of about a 3-month period. And they were pretty much mandatory attendance. We had a really full packed room, and it wasn't just the sales market-facing team. It was the underwriting teams. It was anybody who was really involved in any sort of point of employer-facing conversation. So in these conversations, which were iterative, we spent a lot of time explaining why medical home, well, first of all, even before why medical home, why is primary care so important? Why do you need to understand this? And what do we need differently out of primary care that we're not getting today? And what does that mean in terms of this medical home model? So we spent a lot of time on just the backdrop for this. We viewed these sessions as being highly interactive. So at the beginning or at the end of every session, we would give the sales team an opportunity to give us the yeah, but, or the what about question. So we could say all these things and they sound great, but what are the questions that you anticipate getting? And we could make some of them up ourselves, but it was really great to get them to come to the table with the yeah, but what about questions that they were concerned about getting when they delivered this message to the market. I mentioned already the fact that the payments to the primary care physicians were important, and how meaningful they are could be argued, but they're more meaningful to primary care than they are in the scope of the total impact on the total cost of care. So we really tried to put that investment, what we called an investment in primary care, in a perspective in a couple of different ways. One was just that. I mean, if you really looked at our early days of this, it was less than 1% in impact to total cost of care, what we were doing, and really called that out so folks understood that. But we also really highlighted the fact that Blue Cross, for a good almost 5 years at that point, had really been making this investment on behalf of all of our customers on our own. And we believed in it that much. So I think that was another important key piece of this. And then the final thing I would say, and I think that you have to know our context and where we sit in the community, but I do think Blue Cross, if a health plan is trusted or valued as a partner, I would say Blue Cross of Kansas City is one of those plans that holds that position in this community. And I can't speak enough to how important I think that position is to getting your broker partners, your consultant partners, your employer customers on board, and certainly from a broker consultant perspective, helping you deliver the message, but then from a customer perspective, really embracing that message. So that's sort of the rundown on how we got to where we are today, or how we got to where we were in terms of launching in the market. As salespeople sometimes do, they get competing demands, and Suzanne has been delayed in joining us. So she was going to speak to sort of what our success has been in the market, but I've been close enough to it that I can comment a little bit on that before we open it up to questions. And from that perspective, I would say that a couple things. A, we did build an opt-out mechanism. So we're able to operationalize an opt-out for an employer group. We never really offered it. And we frankly were never really pushed on that. We had one segment that came along a little bit slower than others, but it was a relatively small segment in the scheme of things. But with our large employer customers who we rolled this out to, we really had remarkable success. Now, I won't say it hasn't been without its difficult conversations, One of those is around, well, what is this doing for me today? You know, what does this look like for my employees? And we all know how familiar that question is from a health plan perspective. We were pretty clear early on, and it was part of our messaging to the market, that we will be completely transparent with book of business results, with book of business overviews. We will share with you as much employer-specific data as we can, and we built reports around showing them how many other members were attributed to medical home providers, how their risk scores and or health status of those attributed to medical homes compared to non-medical home providers, how that might be moving over time. But we were very explicit in saying we are not going to share with you employer-specific results because they simply are not credible. We don't have enough, you don't have enough lives, and we don't have a valid comparison point when you get it down to an employer-specific basis. And so far, we've pretty much survived on that, and that has been you know, we've been able to get by with that in the market. Let me just say that. And I shouldn't even say just get by. I think we've been successful in the market on that basis. We will continue to get pushed on that. And as this grows, I think we need to continue to push ourselves to look for what are the comparisons and reference points for this, because it's not just a medical home, non-medical home comparison. It's much different than that. So I think that is, if I move us sort of to next steps, and I'm going to hand it back over to Qiana to sort of talk about some of our ongoing challenges with this. I would say that's one of the significant ones that we are wrestling with today, is how do we continue to make this meaningful to specific employers? So with that, I'm going to turn it back to Qiana, who will wrap it up and open this up for questions.
Thank you, Karen. So in terms of the challenges that still remain for us around all this is data and outcomes and reporting. Largely at the account level, as Karen mentioned. We've been reporting to date at the aggregate level and have very good results to share. As Karen mentioned, we're able to share beyond medical home now and looking at it through the larger lens of all value-based programs as a whole. However, it will come a point where customers will want to see their account-specific results. And so the onus is on us to identify what data points can be shared with smaller numbers involved and be able to do those readily. And so daily conversations occur at that end, but it is very much still a challenge. I will say that because our attribution in our value-based programs is growing significantly, there will also come a point where we are losing a comparison population. And so that's something that we're considering and are contemplating, and how do we continue to reflect the value with a diminishing non-attributed population, or a population that's not attributed to value-based programs. So that will continue to be a challenge. In addition to that, our program and our efforts in alternative payment and care delivery models are largely local in Kansas City. And so as we have customers outside the area, it becomes a challenge to ensure that their employees' experience around advanced primary care and around population health management and how they're impacted by that is the same. And that's very important to employers. And so that's a continual challenge too. So I think those three key areas, data and reporting at the account level, a comparison population with growing attribution, as well as this being a largely local effort, are our challenges that we're actively talking about and trying to solve.
More to that, and this is really funny, pushing the laptop back and forth between us. Hope you guys are getting a kick out of it. But one of the challenges that I would add to that is, Qiana mentioned in terms of level setting at the outset, our movement into the ACO models. And as we see more, if we see the success in those models that we anticipate, the level of payment that has been extremely incremental at this point becomes more significant. That payment occurs when the value improves, and we think we have a really good story there. But I think it goes to the point that I was making earlier about really owning this, and we put it right out there as a line item when we talk about it, and we've built the foundation for understanding of why do this. But I think as that number that we actually affectionately refer to as medical value payments, those non-fee-for-service payments. As that grows, the conversations around that will become much more challenging as well. So with that, Lisa, back to you for questions or comments.
Great. Thank you so much, both of you. This is a great presentation. A couple of questions came in on the chat function, and I'm going to start with that. But before I do that, I'm going to unmute everybody. And if you're not speaking, as I said before, please mute your line if you're not actually actively talking. Okay. One of the specific questions that came in was around every employer in your community, which is Hallmark. And so the question about your conversations were with part of this process.
Sorry, Lisa, we're really struggling to hear that question. There was a lot of echoing again.
Okay, I'm going to mute everybody again. Okay, so the question was specifically about Hallmark, which is a huge employer in Kansas City, and what the types of conversations would have been with them, not that you need to divulge all proprietary secrets, so I'll make that statement right away. You know, I think that that's just a larger question. So what your conversations were sort of geared towards and how your interactions have been.
So with regard to Hallmark specifically, they are not a current customer, have not been a customer of ours throughout this journey. They happen to know they have taken the defined benefit approach with an sort of a private exchange model. So that has not been part of our conversation. We've had extensive conversations with other large employers. Garmin is one in our community that you're familiar with and aware of. Quest is another large, lab entity that is a customer of ours. And I'm not sure exactly how to answer that question, except to say that I think that, the conversations that we had in terms of the buildup with our sales team are very similar to the conversations that we've had in the market with employers. Why do we care about primary care? Why do we believe in it? Why do we think it needs to be different? And more importantly, why we think it needs to be financed differently or funded differently? Because we want different behaviors out of it, and we're not going to get those unless they have the resources to deliver on those. And I think that is the foundational element in this conversation that is so important.
So maybe I could ask a follow-up question then, in terms of what your top, 3 or 5 points you made about the importance of primary care, and in terms of how that. How you're able to, it's not selling, it's really, it's advocating for support of primary care in a more elevated way. What your talking points were?
So I think a couple of those, and Qiana may have some others she might want to add, but one of those is just pointing out, there's a lot of research out there, and we pointed to a lot of the research around primary care that unfortunately the academic and policy world doesn't always share with the commercial world. So I think that was sort of a beginning point, is let's just look at what we know from a research perspective about the importance of primary care. Let's really make sure we understand that, primary care is 4 to 6% of our spending, depending on how you slice and dice that. I love the work that Millbank's doing around that, by the way, today. But, it's a very small percentage of our funding today, and we believe that it's underrepresented in terms of funding. We think that is at the core one of the reasons why it's not delivering the value that we think it has the potential to deliver as the quarterback of the healthcare team. This is a challenging conversation in the U.S. where we don't have any of the sort of primary care drivers and highlighters that other countries to whom we are regularly compared have. We have PPO markets that give everyone freedom of choice to go wherever you want, specialist primary care, it doesn't matter. But I think that it was really sort of turning on the light bulb sometimes and saying, well, wait a minute, maybe that's not the right way to do it. So when we were successful in those employer conversations, what we got pretty quickly was, well, how do I drive all my people to primary care? Or more importantly, how do I really incent them to use medical homes? So, coming up with some approaches where we could use simple things like copay differentials in a PPO construct was something that we did very early on as the result of these employer conversations.
Thanks, Karen. So people are being very kind and cooperative and are submitting their questions on the chat function. So I'll be reading those so we can contain the noise. My apologies for those of you who would like to be speaking. So we have a question that I'm going to read to you. When you crafted the per member per month for the patient-centered medical homes in your commercial population, were you able to demonstrate a reduction in the total cost of care that covered those specific expenses? And if so, how did that data help to demonstrate the value to your self-funded plans?
I think that if I'm understanding the question correctly, is have we covered the cost, or at least early on, did we cover the cost of our PMPM allocations to our providers?
Right. That's
yes.
Right.
Yes, we have all along the way. I don't know from an internal business perspective, from a business case perspective, that we would have come this far had we not been able to do that. And fortunately, we always have. I think that is the value that employers quickly latched onto when they saw the early results from the first few years of the medical home program. And they not only saw that providers were incented and could thereby deliver more care, but that the overall health of the aggregate population improved as well. And so I think we continue, the program continues to perform well and demonstrate its own business case in that regard.
Great, thank you. Sarah, do you have anything to add to that, answer that question?
I was just going to add that in terms of studying the PMPM values and sort of the model overall, we really just adopted the AFP recommendations for the hybrid model at the time. And it was pretty much as simple as that.
Okay.
In terms of our, how do we arrive at a value and what do we do?
Okay, great. So this is a follow-up question then to this on this topic. So the percentage, what percentage more of their actual share of the total cost of care did you give to the practices to allow them to deliver that extra care? And did you continue to pay them fee-for-service and require encounter data? So they had to document that the visits had occurred.
Yeah, so I'm not sure if let me try to answer that. So we continue to pay them fee for service. And in fact, in the early stages of this, and this probably is more of a reflection of where we were with our fee schedules, our physician professional fee schedules at the time, medical home providers received an enhanced fee for service payment plus the care coordination fee. So to be quite frank, I think we felt like we were really playing catch up with those providers. And so it was not an effort to try to rationalize, what percentage of total cost of care do we think you should be. It would be nice to say that at this point, that it was that thoughtful and that, disciplined in our approach, but it was really much more, what do we think is the right payment level for them in the construct of, or in the context of where we were with our overall payment to them at that point in time in the market. But they do still continue to receive an enhanced fee-for-service payment schedule from us. It's not, it's not going to rock anybody's world, and some of them may have even forgotten that it's enhanced at this point, but they do, and they still get the. But I think the real, as we've evolved, if there's interest in the PMPM conversation, as we've evolved our payment model, we started out sort of with the flat payment. Everybody sort of gets the same thing. Bless you, Lisa.
Thank you.
But we, we really more importantly recognize there's a big difference in the commercial population between your average member and your high need member. And we, very quickly started risk adjusting. We've also used the PM payment as a vehicle for reflecting incentives. So cost and quality performance gets reflected in your PM payment as well. It's a really straightforward, mechanism that once we gain some employer understanding around that PMPM value in the market, that we can just sort of build on that.
Great, thank you. I have another question that came in on the chat. This is from Vince Spienberger at CDPHP in the Albany area of New York State. So his question is, what is the progress of other payers' alternative to fee-for-service models offered to employer groups in your market space? So I guess there's a couple parts to this question. I'll just read them off. If greater penetration of such a model should correlate to great buy-in to the model, it seems like that should be the case. And so this is really a question about fairness on some level and leveling the playing field.
Well, Suzanne's joined it, and I'm going to punt that to her to talk about what she's seeing from other payers. But I will say we are totally on board with the fairness comment, and we think everybody should be supporting providers in this space.
Hi.
Good. So in talking with our brokers and consultants, really in our market, feedback I get is that we, and even I work with some of our provider groups as clients as well, and that we still are really the only one doing it. We have another competitor in our market that has now come to the table, but they're very much in the early stages of doing the value-based payment models. So really today in Kansas City, we still in primary care. And really, even though on the accountable care organization front, they're talking about it, but it's still very, very early stages. And that's with another competitor in Kansas City.
And in fact, we believe in this so much. We've been kind of trying to stir things up in the market with broader conversations, with providers, and even inviting other payers to the table to talk about how do we do this differently, this journey from volume to value. What does that really look like locally? But, we're probably, I think, and again, I think it was a Milbank article that came out was it the Curb Your Enthusiasm article, the Milbank piece, where we talked about, really there's about 4% of providers really engaged in risk contracts, so the ACOs, we have sort of our ACOs in title, but not much meat or meaning to them. So we have been really pushing the market, I think, more than anything else.
Great, thank you. I have a question about some of the tools that you've used in terms of working with your colleagues in the market. Specifically, if you could elaborate on those 90-minute sales and marketing education sessions, like what specific topics did you have? Were these open conversations? Did you do some role playing? Would that be helpful? How do they work? Love to learn more about that.
So we did. Karen and team put together some great placemats. So we had also FAQ documents we thought through. The team was really thoughtful on what questions we might expect to have, so that all of our sales team was, I think, very well prepared to go out and talk with the brokers, consultants, as well as the groups. But it was the presentation towards the end, actually, we did some role playing, used some examples, and even, I think, Karen, maybe not you, I don't know that you're involved in that, but we've done some further just underwriting training and role playing within the marketing team to talk about, because we believe in being pretty transparent with our groups about it. So those fees and things are reflected. And so to kind of talk through, if we get questions on that, how do we address those with both the group and the broker consultant.
For internal training, we did also do a fairly significant broker meeting dedicated to this topic before we launched. So it was sort of toward the end of 2014 as we were preparing to launch. We had a pretty sizable and significant broker meeting on this topic.
So just as a follow-up question then are these continuing today? And obviously you have an ever-evolving, set of practices. It's a, shall we say, a fluid market sometimes.
We talk about this with our groups and different meetings in our reviews. So it talks about when we go out and meet with them, what are we seeing from an aggregate level, the results. So those from a discussion point continue to go on with the groups and our brokers. But as far as like formal training, we really, we just have really just dialogue with our brokers, mostly around when we're coming up for renewals and pre-renewal planning, et cetera.
Great, thank you. I don't have any other questions on the chat. I guess I'd like to ask a question in terms of some of the challenges that Qiana had mentioned just a few moments ago, and sort of how you're starting to grapple with some of the data challenges. I know that you have been talking about trying to link with the the all-payer claims or multi-payer claims database that's based in St. Louis, which is obviously a different part of the state, but just how you're trying to marry those things and deal with some of the data issues.
Yeah.
Easy question. I'm so glad I asked it, I'm sure.
Yeah, thank you for that one, Lisa. We can finish on that now. Yeah, data is a continual challenge in this space, as we all know, both making sure that we have the data that reflects accurately what we think the impact of our programs are on employers and on members. And I think more and more that relies on having some sort of clinical quality data picture, as well as just our traditional view of claims data. So our energy is very focused on bringing those clinical quality elements in-house. You know, from a data and analytics perspective, we continue to try to get more sophisticated around understanding what it means to specific employers while not evaluating an ROI at an employer level. So we're spending a lot of time and energy trying to understand how we can tell that story better and differently. I would say that another challenge for us is one that Qiana referenced, which is, you know, what is our reference point? You know, I'm a big believer. It's trend and it's total cost of care. You know, if we manage those big things, then you know, some of this all becomes moot, these comparison of one intervention to another, if we can get our arms around the whole big thing. That sounds great, but it's very hard to do. So, but I think we're spending a lot of time on those conversations. You know, we are, you know, we do see the all-payer claims database which is based out of St. Louis, but is collecting statewide data from all of the national payers who are participating in it. We are joining that all-payer claims database. It's one of the few voluntary all-payer claims databases in the country. Missouri has no legislation to require that today, and if we can all get on board on a voluntary basis, I think all the better. I think we see that as a way to really reflect back to the community what the impact of change means. And so I think that's an exciting opportunity, but it's a very long-term opportunity because we're just really beginning that journey with them.
I think, Lisa, also, aside from the vantage point of operations and what employers need to see, we continue to be challenged by, but are meeting the challenges with what providers need to see as key insights in providing care to our members and their patients. And so that is a continual conversation. We have very strong relationships with our provider partners in this community, and we interface with them quite a bit. And they don't hesitate to tell us what they need. And oftentimes we can get them that relatively quickly, and sometimes it takes time. And so getting them those key insights is a continual hill to climb. And I also think partnering with them and other payers, our competitors and others, to make it easier for them administratively to get us all information to reduce their burden is something that's a priority for us as well.
Thank you. That's it's actually very helpful, and I'm sorry to put you on the hot seat there, but I know that you guys are doing amazing work around data. So another question did come in on the chat. It's a pretty specific technical question, which I'll ask you, and it's if you paid case management fees and the enhanced fee for service mechanism for lives attributed who were generally healthy, so specifically in the pediatric population or young adults without defined disease.
Yeah, so we always have. Since the inception of the program, we pay the enhanced fee for service, and then in the beginning, a flat rate, a flat value for everyone who was in the program. We didn't begin to risk adjust that PM value, I don't know, until like 13, 12, 14, okay, until about 2014. And so yes, anyone who's attributed, including peds, gets that risk adjusted per member per month base payment or care coordination fee.
Okay, great. I'm
Yeah.
just rolling through, making sure I have gotten the questions here. So there was one other that's a little more sort of a broad question, but I think it comes back to challenges. So if there were disadvantages when you made this transition to CPC Plus last year, obviously it's a lot of the same payers, a lot of the same practices. But the question is if, what you've seen as specific things that you would point to that were unique to moving into the CPC Plus space.
So no disadvantages, I would say. I think track 2 challenges us a little bit in that we were not administering a hybrid model that features. And so we've had to take time to build that model and are right now wrapping up socializing what that looks like and how that'll impact providers. That was very important to us to make sure that there was some, not necessarily provider agreement, but some alignment. So I think where that's challenged us the most, however, has been internally with our systems from an IT perspective, being able to configure our payment tools to be able to administer that model. So we figured it out, and we're currently building, or about to start building rather, wrapping up that provider kind of road trip to socialize the model. Track 1 is our medical home program. So we established 3 tiers for our program, and that launched this year. And our established tier is our medical home program. Our developing tier is a tier before established. Folks who aren't quite ready, who are kind of getting their feet wet and in the advanced primary care space. And then our advanced tier aligns with track 2. It's not identical to track 2, but it aligns from a model perspective. So I think that was the biggest challenge, but no disadvantages from my perspective.
Hey, Lisa, if I could go back to just a couple backup follow-ups to some of the earlier questions. The question about do we continue to do training today? One of the things I wanted to point out is that we are blessed with extremely low turnover in our sales and marketing staff. I'm looking at Suzanne, and I think virtually all of the more seasoned sales leaders or consultants who were in the room at that time, 4 years ago, are still in the room today. So we're blessed with that, and they bring on their own, they do a lot of on-the-job training for those new folks. I think if you're a different kind of organization, I would certainly advocate for more of an ongoing sort of training mechanism around this, because I do think that was such an important component to it. And then on the PMPM question and the healthy folks, when we moved to the risk-adjusted PMPM amount, the goal was to keep the providers continuing to have incremental gains on an aggregate basis. So while the payments went down significantly for the young kids and the healthy adults, it went up significantly for those folks that we know are more complex and time consuming and resource intensive to manage. So it's a pretty broad range that exists in that PMPM structure today for us. So those are my parting thoughts.
So thank you for the clarification. That's great. I'm looking at the chat. I see no further questions. Anybody have other questions they'd like to ask? Okay, well, we're just a few minutes shy of the hour. So for the 3 of you in the room in Kansas City, do you have any last things you'd like to share with us, just in terms of thinking about this for the future? You can all join, put your heads together.
We're trying to all get in here. Hi.
Photograph. This is great.
Parting thoughts other than the fact that, again, I find such great value in collaborating with all of you. I enjoyed talking to many of you in Denver, and I look forward to talking to many of you in Baltimore in May and learning from one another. And that's just helpful to us. And so we should keep that going.
Great. Thank you. Really appreciate that feedback. And we're very excited to be moving ahead with this, and especially glad now that we have 4 new regions who are moving into this space now, and many of them on the phone today. So it's just really wonderful. So I think we can probably just wrap up. I'm going to give one other little housekeeping piece of information. Those of you who've been doing the CPC Plus now since the beginning of 17 have been familiar with the Market Update tool, a survey that comes out on a quarterly basis to give us some sense of where along the spectrum of the milestones you see yourselves. And there will be another version of that coming out for the first quarter of 2018, probably early next week. We recognize that there are 4 regions that are only 3 months into CPC Plus activity. And so obviously the way the questions will be answered by those regions will be different than those that have more experience. We'll be able to reflect that in the way that we display the information and analyze it. So we're very excited about getting that. So you'll be hearing from both me and from my new intern, Pooja Nair, who has just joined us in the last couple of weeks. And so look forward to continued communications and then to seeing hopefully many of you in Baltimore in May. Thanks a lot, and I'm sorry about any technical difficulties, but really appreciated people hanging in there and having this. And as I said, this is recorded. We will be able to share that on the website. So for your colleagues who didn't get a chance to listen in, they'll be able to hear it if they wish. Thanks, everybody.
Thank you, Lisa.
Thank you.
Bye.